Hi everyone, I want to talk about chronic renal failure. It's also known as chronic kidney disease. I have published acute renal failure, also known as acute kidney injury. If you haven't listened to that, please kindly do. Check my channel for that. Thank you. So, let's go. Chronic kidney disease or chronic renal failure is a gradual loss of kidney function. This takes months, even up to years. It could actually be from no symptom at all to many symptoms. Could be from acute kidney injury, then getting worse and progressing to chronic kidney disease. It can progress to multi-organ failure or lead to loss of complications. It may end with end stage renal disease that may eventually lead to death. Urinalysis and serum. Urinalysis will help in making definitive diagnosis with albumin, while serum will also be very helpful with estimated glomerular filtration rate. Chronic kidney disease could be defined further using some parameters like albumin and glomerular filtration rate. Urinary albumin greater than or equal to 30 mg per day is a sign that the kidney is damaged. If you assay the serum and you estimate glomerular filtration rate, anything less than 60 ml per minute per 1.73 meters square is pointing to decreased kidney function. Regardless of the cause or causes, when you are able to pick the two parameters above and you have experienced that in this patient for about 3 months, then we are dealing with chronic kidney disease. Let me recap. In the space of 3 months, if an individual could have urinary albumin greater than or equal to 30 mg per day, or estimated glomerular filtration rate is less than 60 ml per minute, then in 3 months, having both, it is equal to chronic kidney disease. Note this, chronic kidney disease increases the chances of mortality in cardiovascular disease-related deaths. Therefore, we have to take measures to prevent cardiovascular diseases in chronic kidney disease patients. And chronic kidney disease progresses to end-stage renal disease in many and eventual mortality. Glomerular filtration rate is the key to appropriately monitor acute kidney injury progression to chronic kidney disease. Glomerular filtration rate is also useful in determining improvement or not when we are managing chronic kidney disease. We have to refer immediately to specialists if we're finding one of these. 1. Increased albumin to creatinine ratio greater than 300 mg per gram, or we're finding urinary red blood cell cast during urinalysis. If we get one of these, we have to refer. What would the history be like in chronic kidney disease? It might be asymptomatic, or the individual is on dialysis already, or there is history of streptococcal infection, particularly in children, and now the child has come down with post-streptococcal glomerulonephritis. Might be dealing with autoimmune condition here with systemic lupus erythematosus or lupus nephritis. The individual could complain about cloudy urine or hematuria. can present with generalized body swelling known as anasarca. And family history is very essential, particularly family history of kidney diseases, particularly end-stage renal disease. Hypertension, either in the affected patient or as part of the family history, is a very strong risk factor. Mineral and bone disorders, hyperkalemia, glomerulonephritis, and of course polycystic kidney disease. If we are meeting these patients after chronic kidney disease has developed in him or her, we might be dealing with hyperuremic state, and the history will include nausea, vomiting, anorexia. Pericarditis could be diagnosed at this time, history of bleeding, peripheral neuropathy, become lethargic, could even be having seizures, might be in coma, and eventual death. We have to assay blood urea nitrogen and creatinine. We can't use blood urea nitrogen and creatinine to judge the symptoms. Why? Some cases will progress while some will be stable. But that may be a factor of the cause of the chronic kidney disease, the comorbidity situation, the treatment already given, the socioeconomic status, the genetic of the family history, and of course, the repeated episodes of acute kidney injury. Staging. Staging depends on the causes, depends on the value of estimated glomerular filtration rate and albuminuria. We are going to adopt the Kidney Disease Improving Global Outcomes, that is KIDGO, as the diagnostic instrument. So estimated glomerular filtration rate for staging will go as follows. For G1, that is estimated glomerular filtration rate is greater than or equal to 90 mL per minute, means the individual is fine. For G2, it's 9 to 60 mL per minute. G3A, 59 to 45. G3B, 44 to 30. G4, 29 to 15. And G5 less than 15. How do we interpret this? When you find G1, that is when eGFR, estimated glomerular filtration rate in mils per minute, is greater than or equal to 90 mils per minute, that is normal. But when we are dealing with G2 or G3A, that is between 89 mils per minute and 45 mils per minute, then we are dealing with mild chronic renal disease. But when we have G3B, that is the estimated glomerular filtration rate is between 44 mils per minute and 30 mils per minute, then we are dealing with moderate chronic kidney disease. If we have G4, that is estimated glomerular filtration rate between 29 down to 15 mils per minute, we are dealing with severe decreased renal function. And of course, when we have estimated glomerular filtration rate less than 15 mils per minute, we are dealing with profound kidney failure or end-stage renal disease with or without dialysis. Using albuminuria to determine the status of the kidney, A1 is albumin less than 30 mg per day, and that is normal. A2 is albumin between 30 to 300 mg per day. That is still considered moderate. But A3 means the albumin level in the urine, albuminuria level, is greater than 300 milligrams per day. Then we are dealing with severe kidney disease. Other investigations that we can carry out in the course of the investigations before we embark on definitive treatment will include arterial blood gases. And of course, I've talked about analysis. You can still look for casts of so many things there. Urine microscopy, culture and sensitivity, complete blood counts, electrolytes, particularly potassium and calcium, including magnesium and phosphate, liver function test because of possibility of hepatorenal failure, thyroid function test, glucose because there is possibility of diabetic nephropathy, blood urea, nitrogen, and creatinine already talked about. And of course, we can have radiological investigation using ultrasound and CT. Treatment. First of all, we have to look for and treat all reversible causes. As a matter of fact, I will make a separate presentation on causes of kidney failure. I will talk about pre-renal, renal, and post-renal causes. So the first thing to look out for will be the reversible causes. For example, we have to make sure that all obstructive causes are diagnosed and treated immediately. Then we have to work on how to slow the progression. We have to treat all possible complications and use estimated glomerular filtration rate to determine the medications and, of course, the dosages. Renal replacement therapy might be administered here using hemodialysis, peritoneal dialysis, and the ultimate, the definitive management of worsening chronic kidney disease is kidney transplant. Treatment still continues as if you are dealing with reversible causes. You can check my video on pre-renal, renal, and post-renal causes of kidney disease. For example, if the pre-renal is involving vomiting, diarrhea, and hemorrhage leading to hypovolemia, all we need to do here is treat with fluid replacement. If this is as a result of nephrotoxic medications, then you stop them. For example, aminoglycosides, NSAIDs, contrast media, and so on. Be careful with drugs that can increase estimated glomerular filtration rate. Okay, so when an individual is on these medications like cimetidine, trimethoprim, carbamazepine, or flucytosine, the eGFR will be increased and given a false report. So when the eGFR is increased, there's that false belief that the kidney is working well. So be careful with cimetidine, trimethoprim, carbamazepine, or flucytosine. Still on reversible causes, handle post-renal urinary tract obstruction appropriately. Treat hypertension, hyperlipidemia, metabolic acidosis, and tubular interstitial diseases immediately. We need to set a blood pressure goal, and we treat diabetes mellitus. We can use angiotensin converting enzyme inhibitor or angiotensin receptor blockers, but we have to be careful with increased potassium and decreased glomerular filtration rate. Therefore, we don't use ACE inhibitors or angiotensin receptor blockers in solitary kidney or bilateral kidney with renal artery stenosis bilaterally. Still on reversible causes on the treatment, we have to restrict protein intake to 0.8 gram per kilogram per day. And of course, smoking should be stopped. I have published through presentations on smoking cessation. You can check my channel for that. Supplemental bicarbonate should be administered if you're dealing with low pH, but be careful about that. I cannot overemphasize the importance of knowing the glucose level. You can have glucose level control because you might be dealing with diabetic mellitus and nephropathy. Correct increased potassium, that is hyperkalemia, depending on the level of the potassium. It's not all the time that we're going to jab the patient with either gluconate. Not all the time we give calcium gluconate, give insulin, give glucose or salbutamol or caselate. No, it depends on the value of the potassium. As a matter of fact, I have published a separate presentation on hyperkalemia. You can check my channel for that. We have to correct increased phosphate using phosphate binders and decreasing phosphate intake. We have to correct the increased lipid level, and the individual could be taking fat at 30 to 40% using polyunsaturated to saturated ratio 1:1. Still on reversible causes, the sodium intake should be nothing greater than 2 grams. If it is less, that's fine. Iron should be greater than or equal to 10 to 18 milligrams per day. Do you know why? We'll be dealing with anemia in chronic kidney disease. Because erythropoietin is produced by the kidney and now kidney is suffering. So we're down with low level of erythropoietin, so chronic anemia. Water should be restricted to 750 ml to 1.5 liters. Anemia correction with erythropoietin, just as I've said, some seconds ago, we'll be dealing with normocystic normochromic anemia here, anemia of chronic disease, because erythropoietin level will be down. We can use loop diuretics, but we have to monitor the electrolytes. But sometimes it could be at severe end. If the level of the potassium is dropping too fast, then we can use potassium sparing in combination with loop diuretics. There's that possibility of renal osteodystrophy. I'll make a separate presentation on renal osteodystrophy not long from now. Still on reversible causes and the treatment. Someone is saying, oh my goodness, this is just too much. No, that is chronic kidney disease. We have to replace calcitriol. That is vitamin D. It is secreted in the kidney, but that will drop in the face of chronic kidney disease or end stage renal disease. Cinacalcet will be good for secondary hyperparathyroidism. And you have to check the hemoglobin periodically, or at least every 3 months and monthly if on hemodialysis. If estimated glomerular filtration rate is normal and hemoglobin is low, then we have to look for other causes of anemia. For example, you have to rule out B12 or iron deficiency and so on. Some men will be dealing with sexual dysfunction and you have to treat appropriately. Correct malnutrition when it is applicable. Uremic bleeding in the face of chronic kidney disease. That is as a result of impaired platelet function. Okay, so we have to correct the platelets. We can use desmopressin, cryoprecipitate, estrogen, and dialysis. Pericarditis from uremic pericarditis should be treated. And of course, uremic encephalopathy and neuropathy should be treated. Thyroid dysfunction leading to hypothyroidism should be corrected. And in the face of increased infection, we treat appropriately. But we have to be careful using estimated glomerular filtration rate and the level of albumin to determine the dosage of the appropriate antibiotics. Annual immunization is a must. Flu shot must be given. Hepatitis B and pneumococcal polysaccharide and titine-valent conjugate should be administered according to the age and the history of previous immunizations. Ophthalmoscopy is necessary because of the possibility of uremic amaurosis. We have to refer if we are faced with estimated glomerular filtration rate less than 30 mL per minute, or we've done all that ought to have been done, but we're not winning, then we refer immediately. Delay in referral is detrimental to the patient and to us as healthcare provider, and it can lead to mortality and even worsen the situation for the patient, leading to end-stage renal disease and mortality. And with that, I've come to the end of this very presentation. The next presentation will be end-stage renal disease with glomerular filtration rate less than 15 mL per minute. If we're faced with that, what are we going to do? Thanks for listening to my presentation. Very soon also, I'm going to publish all causes of kidney disease or renal failure. I appreciate. Remember to share and subscribe to my channel so that you can get all my publications immediately they are released. I appreciate it.